welcoming you to the Restorative Crown and Bridge from Material Choices to Patient Acceptance. It is a webinar being presented by our very own Dennis Urban, CDT. And now I turn to Ken Gray. He is our Director of DSOs, Institution and Government. He will be introducing tonight's speaker. And also, please feel free to reach out to him directly with any suggestions or questions around what you would like to learn about in the future. Take it away, Ken.
Good evening, everybody, and Happy New Year to you. We're so pleased and humbled time to spend with you. And so we just want to thank you. We appreciate the partnership that we enjoy with Interdent. It's getting stronger and stronger. Again, we just want you to, we just want to express our appreciation for everything. The communication at the office level, at the management level. And if there's anything that I can do, please feel free to reach out to me directly. Or reach to Teresa, and she can reach out to me directly. And with that, I want to introduce somebody that I've known in dentistry now for what, Dennis, over 28 years.
Yeah, long time.
Do we remember? Did we meet on a golf course? Is that where we met?
That's where we met. Yeah.
Years and years ago. So Dennis and I kind of went our separate ways for a while. So I'm so thankful to be back on the same team with him. I've been with DSG, which is now NDX, as you well know, now for just over a year. And it's been awesome to get to work with our education department. They're so talented. They have so many resources that they're willing to share with you. So with that, I'm going to go ahead and introduce Dennis real quick so I can turn it over to him. Dennis Urban is a CDT. He brings 40 plus years of dental technology field experience, including lab management, technical sales, sales and marketing, product development, and quality assurance. In addition to being a seasoned dental lab manager, Dennis has been lecturing worldwide since 1985. His lectures and trainings span many areas of dental technology to include denture setups, digital technology, denture processing, lab management, implant overdentures and bar design protocol, all on 4 and 6 case planning and chairside conversions, shade communication, occlusion, and soft liners. His technical articles have been published in publications across the US, Canada, Europe, and Dennis has been president of both the Long Island Dental Lab Association and the Dental Laboratory Association of the state of New York. He was a Cal Lab board member, is the current board president and on the National Board of Certification, and serves on the advisory board for IDT magazine. And with that, I will turn it over to you, Dennis.
Thank you so much, Ken. Boy, you make me sound old. Man, I don't feel that old. But thank you so much. This is Ken mentioned some of my experience, but I also have experience in Crown and Bridge. And I remember when I started out in dental technology and in the dental laboratory, half the day I would be on the Crown and Bridge side of the lab, and the other half I would be on the removable side. And after many years, I decided to stick on the denture side. But I was still pulled into the Crown and Bridge side every once in a while. But I know the material choices, and I know what's successful for patients. And I really appreciate all of you being here tonight. This is going to be broken down into 3 segments. The first one is going to be the restorative crown and bridge segment from material choices with alloys. And we're going to talk a little bit about PFMs and materials. And then from that, we're going to move into impression techniques. And we're going to stick with the traditional impression techniques. If we have time, I'd like to get into digital, but I don't think we're going to have time tonight. And then from there, we're going to go into a very important topic, and that's shade communication. So we have a lot of material to choose from to listen to tonight. And I appreciate you having me and giving me the opportunity to talk about this. And like Ken said, I've been doing this a long time, and I've been through the stages of where we've developed over the years, both in crown and bridge and on a removable side. And there's been a lot of change. And I think change is really occurring very quickly at a rapid pace, especially in the last 5 to 6 years. And we have to keep up with those choices. But I'm going to show you a couple of slides in the beginning here, and just to show you where we're going to be going. Let me just click here. Let's see if this works. There we go. But as far as what we're going to have a PFM overview in the beginning here, and we're going to talk about anything from prep design to cements and alloys. But you're going to be the first to see this next slide, and this is a survey that was just recently done around the country with dental laboratories and the restorations they are receiving from dentists. And I obviously had the opportunity to get these slides from the National Association of Dental Laboratory, and I'll show you what it says here. And it talks about materials and the percentage of crown and bridge sales by type. And if you look at the the different categories here, we look at PFMs, and porcelain fused to metal is only 6% of the national laboratory business now in laboratories. So we come a long way. And look over here, full contour zirconia is. That's 48% of the business that laboratories are getting across the country. And then we go into all ceramic. We'll touch on these in a little while. And base, noble, and non-precious PFMs, it's about 6%. And pretty much 6% across the board, until we get to that high noble precious PFM content. That's pretty much about 5%. And then provisionals is 4%. So we really changed a lot, over the years as far as where we were way back when, and I'll talk about that in a second. But even with other techniques, like a few years back, press to metal was hot. I mean, everybody wanted to get on board utilizing press to metal. I remember working for a company, and they used to sell a lot of press to metal products, and I was a technical advisor there, and it was just like we couldn't keep up, But now it's the percentage that they're doing is hardly any. It's more than 50% of the laboratories are doing ceramic work, and 89% of the labs do not even use press to metal products anymore, So, and I'm not saying this to put a negative aspect on PFMs. I think it's still a viable, important product in a laboratory, and it's viable for patients and for patient satisfaction. But there's a lot of other options out there. But tonight we're going to talk about the success of PFMs, and they work really well. Matter of fact, in my mouth, I think I have six or seven PFMs in my mouth, and they're great. They're aesthetic and they work great, and they're functional. So with that, we're going to get started with the presentation here. So we talk about porcelain fused to metal. Porcelain fused to metal restorations have been the mainstay of prosthetic dentistry for more than a half a century. And the flexibility in design from no exposed metal to metal occlusals allows the PFM to be utilized in many clinical situations, including parafunctional and limited space. And PFMs work well as single units and bridges and is designed by your preferences for each case. And the PFM was actually invented around in 1959. And before that, you saw a lot with cast gold. Cast gold was previously used, but not for anterior teeth. But then we started getting, as time went on, we had ceramic systems come out, but they had many failures. They weren't strong. The bonding issues were there. The aesthetic issues were there. So PFMs really took foothold, in the industry, and then it was challenged. In 2007, we had lithium disilicate. Disilicate was introduced and really, really changed the whole landscape of PFMs and restorations. And then we had solid zirconia come around 2009. Well, and we'll talk about that a little bit more later, but I want to focus right now on PFMs. So again, PFM, it's a tried and true restoration, and it provides strength and durability. And the PFM could be the only option for those difficult and complex situations. It requires precision attachments. How many cases I've seen over the years of precision attachments, or we needed high strain situations with minimal room. Even some of my PFMs, I have to have metal occlusals because my bite was tight and there wasn't even enough room for porcelain. And we can't do that with the ceramic restorations, although they'll break, if you don't have enough room. And it was the ideal situation for bridges, both anterior and posterior. And strength and durability is there. They're great for large span bridges, as I mentioned, and for cases with minimal occlusal space. So one of the contraindications is for highly aesthetic cases with minimal prep reduction. In that case, thankfully, we have the other alternatives with zirconia and lithium disilicate and those types of restorations. So we have all these options today to choose from to give that patient the satisfaction and the acceptance that the patient needs. So as far as preparations, for the PFM to be successful, the tooth must be properly prepared, and often substantial tooth reduction is required. And I can't tell you how many times in the laboratory I had to get on the phone and call the doctor up because there was a minimal amount of space that I had to put porcelain. And this is important, especially when you have putting porcelain even on the buccal or incisal. If you don't have that much room, it's not going to look aesthetic, and it's going to affect the shade integrity. So we know substantial tooth reduction is required. We'll talk about more preparation in a few minutes, but the crown must be sufficiently thick enough to hide the metal substructure. And remember, we had to put opaque, we have to put different layers of porcelain on here, and and we have to amass that alloy with the patient's porcelain. And we're preparing a tooth. A systematic and organized approach helps to ensure the prep is correctly shaped. So, tooth preparation involves several distinct steps, which include creating the guiding grooves for incisal or occlusal reduction and reducing the labial or buccal surfaces and axillary reduction for the lingual and proximal surfaces. So we have to keep that in mind, and furthermore, with preparations, you see here, if we have that 1.5 millimeters from where the prep is to where the porcelain is, that's perfect. That's good enough room for us to do our job and to give the correct occlusion and thickness that we need and strength. And you can either use a shoulder margin or a feather or chamfer margin. You have, it's a lot. You have a lot of choices. So for me, PFMs are pretty user friendly, but we'll get to the kind of not the negative, but the challenging aspect of it. We talk about alloys and porcelain. So any margin style, like I just mentioned, ideally 1.5 millimeters of interocclusal space for optimal aesthetics, and any margin design with 1 to 1.5 millimeters for reduction of color. We need that shade integrity. And we're going to talk about that more when we talk about the shade science and communication segment of this presentation. And 1.5 to 2 millimeters reduction at the incisal or occlusal or facial. And if you wanted a porcelain margin, be sure to use a shoulder prep. And if patient suffers from bruxism, we're going to use metal occlusion like I have on some of my posterior crowns. And I've had them for years. I'm thinking about moving over to some zirconia restorations, maybe towards the anterior in the future. But these have been tried and true for many years now and have provided a lot of success, with me and many other patients. So when you're preparing those posterior teeth for PFM crowns, a lingual chamfer and a buccal shoulder are created. And the buccal shoulder preparation should extend at least 1 millimeter lingually to the proximal contact. And that preparation should extend slightly further medially than distally, and as it's more visible in that area. So the occlusal surface of the posterior teeth, like I mentioned, about 1.5 millimeters would be great. 2 millimeters would be even better. Occlusal reduction may be less if the crown is fabricated with metal occlusal surfaces. So, and all margins should be clear and defined, and all other angles must be rounded. And we're going to touch on this aspect a little bit when we talk about impression taking also, because still the number one call we make in the laboratories is on impressions, and also if we don't have a clear dye, that we can't read the dye, we can't read the prep correctly. So the finished preparation should not have any obvious burr marks on them. And we see that a lot also. Those burr marks is going to interfere with we're going to have to block those out, and it might affect the fit. So a porcelain marking requires proper support, and a 90-degree angle is preferable. And the shoulder is also suitable for crowns and conventional metal collars, allowing that collar to be kept narrow and unobtrusive. So embeveling that margin or sloping it down allows for the porcelain to be better supported. So I'm a big fan of that beveled margin. So what about anterior PFM presentations? Well, anterior preparations, anterior teeth should be reduced by, again, 1.2 millimeters on its labial surface. And although 1.5 millimeters is the preferable size, we can get away with 1.2. And on lingual surfaces, they're reduced about 1 millimeter and incisally by about 2 millimeters using a rotary instrument. And there's a lot of different burr kits out there to take you step by step through these different procedures of prepping. And to successfully prepare the labial surface, a central cervical groove should be made parallel to both the path of placement along the long axis of the tooth. And 2 further secondary grooves are made on either side of the tooth there. And incisal edge reduction grooves are placed, and these must be approximately about 1.8 millimeters deep. So, like I mentioned before, there's a lot of different prep kits out there that really work well with different restorations, with anterior, posterior PFMs, and also with zirconia and lithium disilicate restorations. So, and when that incisal edge is reduced and proximal contact is broken, ideally the incisal edge on an anterior tooth should be reduced, like I mentioned, about 2 millimeters. It's going to allow for the adequate material thickness. And we need that adequate material thickness, especially on the anterior. We want something that's going to, look natural. We want translucency. We want natural shade. We want opalescence, and we want something to look really aesthetic and something that's going to be pleasing to the patient. And again, the proximal contacts, they're reduced about 0.5 millimeter lingual, and a chamfer is created. And the tooth structure between the depth groove is removed, and that creates a cervical shoulder that should be approximately 1 millimeter wide. That should extend into the proximal embrasures. So I mentioned before about layering porcelain. I can't talk too much. I don't have too much time to talk about layering porcelain today. But you can see here, when you see this tooth in the middle here, what happens, when we're layering, we have that metal substructure, and then we have to layer this porcelain with the different levels of porcelain that we use, the opaque, the base dentin, the dental, and the enamel. And so we need to have enough thickness there to allow the light to flow through the restoration to make it look natural, like a natural tooth. We'll talk about this more in the presentation with the shade technique. So, and cementation, very simple. Any resin modified glass ionomer luting agent is great, works out really well. A lot of choices on the market. I remember, way back when I was working, Ken knows me, I think from my GC days, GC America, one of the companies I used to work with, when resin reinforced or resin modified glass ionomer cement came out, they were one of the first, and they were based out of Japan. We couldn't keep up with the sales. It was just, the demand was just crazy, So, and the reason being, the regular glass ionomer cements we had some problems with. So let's talk about types of alloys to use on PFMs. The metal substructure of a PFM can be made out of any one of a number of dental alloys. Of course, we have high noble, which is precious alloy, and these alloys have over 60% gold, platinum, and or palladium content. And the high noble metals were one of the easiest alloys to adjust. And yellow gold high noble metal offers the best aesthetics over any other PFM restoration. And then we have noble alloys. I'm going to elaborate more on this in a few slides here. Noble alloys with semi-precious, these alloys have over 25% noble metal, and that includes at times gold, platinum, and palladium content. And noble metal crowns offer more of a hypoallergenic restoration over a base metal crown at more of a affordable cost over high noble crowns, but that's changing a little bit. I'm going to talk about that, the palladium prices versus the gold prices in a little while. So those it changed a little bit, and the market changed about a year and a half ago, and palladium started really skyrocketing. So, and then we have a base non-precious metal, and that contains less than 25% low noble metal, and those base alloys are considered to be the most economical PFM restorations. Most base alloys contain nickel, chrome, or not so much anymore of beryllium. They've kind of eliminated the beryllium out of these non-precious metals now. And there's your insurance codes. We have dental insurance codes right here for porcelain fused to metal, high noble, base metal, and noble metal. So these are still in demand, but not as much as they used to be as far as those types of restorations. And then we have a full cast crown. And I was, it's funny because when I got my crowns and my molars, I was my doctor was talking me into full gold crowns on my molars. And I think back now, I probably should have done it, because from what I'm hearing about the success of full gold crowns and full PFM, full gold crowns and posteriors, it's been very successful. And they have a long history, providing strength in the posterior with minimal preparation, which is great. And they could also be digitally designed and milled in wax prior to casting for consistent quality results. They have a proven track record, like I mentioned, and kind to the opposing natural dentition, strong, minimal prep, longevity is there. And when we digital design these on a number of different softwares on the market, and it's very easy. The software today makes life a lot easier with these designs. As long as we have a good impression and we have something to follow along with as far as quality impressions and preps. So, and they're ideal for the posterior region, where there's no minimum room outside of the aesthetic zone. And the contraindications, the cosmetic restorations, you really can't have high cosmetic restoration on the anterior with full gold crowns. Although I see that once in a while with the anterior crowns being full gold. Cementation is the same as as we saw with the PFMs, resin modified glass ionomer cement or luting cement. And what I said before about the glass ionomer cements, the original ones, the original glass ionomers had shorter working time. They had low strength and toughness, and it had a lot of cracking and poor resistance to acid attacks. So there wasn't really a good long-term solution for cementing these types of crowns, and it had moisture sensitivity. So when they had the resin reinforced glass ionomer cements come out on the market, it just eliminated a lot of these negative aspects of glass ionomer cements. And preparation, any margin style, ideally with 1 millimeter of occlusal space and feather edge margin preparations. However, any margin preparation may be used for these full cast crowns. And then there's your dental insurance codes on these full cast crowns also. So I just wanted to touch a little bit about, I'd like to give a little bit of back to basics when I talk about some of these things here, and I wanted to talk a little bit about where we are in the PFM industry in this country, and where we're headed. But one of the most important aspects of PFMs is the metal and the alloy that you're using, and we're going to get into that now. So let's talk about dental alloys and talk about a little bit of an overview with dental alloys here. So dental alloys, as you know, they're used for casting a range of restorations, copings, frames, and even more. I remember the day, and I'm getting away from crown and bridge now, when I first started out in the dental lab business, it shows my age now, we did a lot of gold partials also, a lot of gold partial frameworks, for dentures. And over the years, because of the expense of the gold, we got away from that, but they can be, the gold and precious and noble alloys can be used for so many different restorations. And they can be composed of a range of noble, high noble, and base metals, and each mixture offers different properties that can make one alloy ideal for a specific restoration over another alloy. Full contour crowns and bridges are most often cast from noble and high noble metals, such as gold and platinum and palladium. The softer metals might not be suited for posterior crowns on approaching patient, like I mentioned earlier. So we have a large, a range of alloys that can be used. There are hundreds and hundreds of alloys on the market from different companies around the world, and it can get confusing. So it's important to coordinate the alloy and the ceramic systems, being used for a PFM restoration. Because specific alloy requires specific techniques with different alloys melting at different temperatures. So we need to follow the protocols that deliver the best results for each restoration. So it's really important because I was also in working for a porcelain company at the same time we sold alloys also with one company I worked for, and we used to get so many calls. We had about maybe 15 to 20 sales managers on the phone every day, just answering questions about dental alloys and the CTE requirements for each alloy for a successful PFM crown. And that was back in the days where a lot of gold and a lot of semi-precious metal was being sold. And, the coefficients of thermal expansion of the porcelain and the alloy had to be compatible, and then we saw a lot with, different alloys, especially with silver. We used to get a lot of greening, which there was a high silver content in the alloys. We used to get greening, and sometimes we get too much oxidation and the porcelain would chip off, or the bonding wasn't that great. So when those differences exist, changes to the cooling schedule that their firing might be required to reduce the stress caused by thermal expansion of the coefficient mismatches. So we ran into a lot of different situations over the years, especially when things went over from the gold from being so high. A lot of laboratories and dentists were going over to prescribing more of the non-precious alloys. So we ran into some challenges in the beginning with non-precious alloys because of the bonding issues on to the porcelain, because it's the CTE factors. So which alloy for rich restoration? We have high noble, and then we have non-precious. First thing we need to do, though, is communicate. So between the dentist and the dental laboratory, it's really important. I talk about communication all the time with case planning, anything from a simple denture to a really involved case involving a full arch case with implants. Really important to communicate. I don't care if it's a simple case or sometimes things get lost in communication. So the practitioner and certified dental technician we have to have an agreed understanding about what type of case and which materials to use, including dental alloys. And we need to have the correct information on the RX at the laboratory. Laboratory prescriptions should specify the materials that you need or you wish to be used. And we still get a lot of doctors writing down what alloy they want to be used, the percentage of gold versus palladium and things like that. And we got that information, which is great. And we love to have the history of the patient. Did the patient have a history of bad bruxism? They have previous PFMs that didn't work out, or they just didn't last in the mouth. They broke or chipped. We need to know all that information in the laboratory. This way we can help plan the case in the correct way. And the collaboration on case planning and the correct materials, it's going to lead to patient satisfaction and acceptance. So it's really important that we have the communication between us and you, the dentist. So let's talk about high noble alloys. So precious alloys, these have an over 60% global platinum, and high noble metal is one of the easiest alloys to adjust, like I mentioned earlier. So, the thing is, they're great for full cast crowns. Some of the high noble alloys, that we have on the market are the combinations you see on the bottom here. Compositions of gold, silver, copper, palladium, indium, iridium, and zinc. There's a lot of different contents in each specific alloy, and this group has a composition that's over 60% noble metal, and of which more than 40% must be gold in order to qualify for a high noble alloy. So you can see the differences down here. Look at alloy color, composition. You can go anywhere from 77% gold all the way down to 48% gold. But as long as you have those other metals in there, it has to be 60% noble to qualify for that high noble. So, and the noble alloys, which is most widely used when we're doing PFMs, is they have to have at least 25% of noble metal content. And these are just a couple of examples I can see here. 20% gold, 20% palladium, silver, indium, zinc. And, one of the things we had problems with in the past, like I think I mentioned earlier, was silver palladium. And that silver had an effect on our crown. So we really had to adjust what alloy we were utilizing for a specific porcelain. So, and according to the FDA staff, their Class 2 Special Controls Guidance Document on dental metal alloys, well, they may be primarily composed of gold, silver, platinum, or palladium, but lesser amounts of other elements such as copper and zinc. But they're for crown and bridges, copings or substrate to which a fused ceramic coating is for. But the classification includes cast and porcelain fused to metal noble alloys and specific solders for each one. All right, how about biocompatibility? Yep, the biocompatibility of noble alloys is equally important as other physical or chemical properties. So the biocompatibility of noble alloys is primarily related to elemental release from these alloys or their corrosion. And this is interesting because any toxic, allergic, or other adverse biological response is primarily influenced by the elements released from these alloys in the oral cavity, and that's from the corrosion. And some elements include copper, zinc, silver, nickel. Nickel is a big factor. I remember my mother getting a crown, and she had a non-precious crown. It was nickel, and she had a very bad allergic reaction, and we had to take that crown out and make her as a semi-precious crown. And they're inherently more prone to be released on these types of alloys from dental alloys, such as than gold or palladium or platinum or indium. And alloys with high noble metal content generally release less atoms than those alloys with little noble metal content, like I just mentioned. So it's estimated that about 10 to 20% of females have an allergic response to nickel, like I just mentioned, as far as when my mother got her crowns. And this incidence rate for men is lower and possibly as low as 5%. That's pretty interesting. So sensitivity to palladium generally runs about a third that of nickel. But also for those who are allergic to nickel, it's the allergic response experience is typically benign. But it's associated with itching and can affect the person's quality of life. In some cases, you have really bad rashes in the mouth. And besides just the mouth, other parts of the person's body can be affected also. So in cases where there's a question about mental sensitivity, prior to restoration construction, dermatological patch tests can be used to evaluate the patient's status. And we did this also on, not only with crown and bridge, but on a removable side with dentures and different various acrylics and polymers and monomers. When patients were getting allergic reactions, we'd have a dermatological test, including patches made out of little pieces of acrylic. And the same thing is done on the alloy side. So one of the things that we could use just to make sure that you're getting the correct alloy, something that was invented a number of years back is called iDentaloy. And iDentaloy and iDentaceram for ceramics, they're certificates that reflect an unbroken chain of added value and due diligence from top manufacturers and suppliers to labs, dentists, and patients. So you should be getting a iDental alloy certificate with each restoration, just to give you a breakdown of what's in that alloy. And for many years, it's quite funny because we had this campaign, we still have it running now at NADL, called "What's in Your Mouth," and a lot of it derived from over the years. Patients didn't know what they were getting in their mouth, and doctors a lot of times didn't know what was in the alloy they were getting. So these are identified certificates. I really like this system. It's been out a long time, and you should, like I said, you should be getting this with your restorations, and it's going to ensure that the material you get is actually the material that's going into the patient's mouth, and it's recorded on the patient's file, and he or she can obtain a free verification through the Dental Alloy and DentaCeram certificate program. So certificates are sent at no charge, and you just have to go to that website, dentalalloy.org, and you can get that information. So great system, it just, even with ceramics, I can't tell you over the years, especially when I was working for a porcelain manufacturer, some of the porcelains that were being bought around the country in laboratories that didn't follow FDA or ADA guidance, it was horrible, so that's why we wanted to, they weren't lasting, they were fracturing, they weren't healthy for the patient. And that's why they came along with this dental alloy and Identalys for ceramics also. So let's talk a little bit about non-precious. These alloys are also referred to as base metals, and the noble metal is less than 25%. So they often contain large percentages of nickel, cobalt, chromium, and not so much beryllium anymore, because that was a cancer-causing agent at the time. So, we have, some of the non-precious alloys, or the silver, and they have white, they even have gold colored non-precious alloys now. But you see the composition variances here. There's so many different percentages of base metals in these non-precious metals, as you can see here. So again, it's really important. We have to know what the CT is compared to the porcelain that's being used. So, but on the positive side, non-precious metal alloys are available in dental technology for casting procedures. Now they have powders for 3D printing technology, and they're fully dense blanks for milling techniques, and for SLM copings, with the sintered lasered copings that are made. Really, really amazing. The fit is amazing and accurate. And these new cobalt chromium blanks are now available and being milled in the green state, and then densely sintered. So, and the same thing is being done with partial denture cases now, with sintered partial frames. And the fit and look and and even the functionality of these is fantastic. So handling is considerably improved by new technologies that are available for chrome, cobalt, and alloys, and especially for CAD/CAM and 3D printing. So those labor-intensive and error-prone casting procedures from years ago, they're pretty much gone now. So there's still a lot of laboratories using torch method, but we'll talk about induction casting and those types of methods in a little while for melting this alloy. But that time-consuming manual working stages are really no longer required. And because of the fast evolution of 3D printing techniques, chrome cobalt alloys and prosthetic dental applications have to be considered as a serious competitor. And you're going to see more and more of this technology, in the future. So let's talk about casting. So this is what we used years ago. This is when I learned how to cast alloys. We used a centrifugal arm here, and we had like this big metal barrel in the laboratory, and we'd have a torch, with oxygen and compressed air, and we couldn't really get a lot of times consistent castings with this type of casting method. With gold, maybe with precious metals we did, but when we got into more of the semi-precious and even the non-precious, it was kind of difficult. So we come a long way with casting methods, and there's still a lot of laboratories using the regular manual casting procedures. But I remember a lot of hours learning how to cast, and one thing that sticks in my mind. One time I was casting non-precious metal in a laboratory, and somebody came through the door. I happened to turn my head. I let the centrifugal arm go, and the alloy just went flying across the laboratory. And this is molten alloy, and just missed the person walking in the door. And I remember little fires starting on the bench and creating holes in the bench. And so when that happened, I said, you know what? I'm going to look into. I had my laboratory. We're going to look into an induction casting unit, and that's what changed my mind. So safety reasons. That was a really close call at the time. So challenges with alloys. You can see this guy pulling his hair out. This is what a lot of the technicians go through in the laboratories, with all these different challenges with the alloys over the years. With heat tears, brittle alloy, quenching, overheated investment, porosity, overheated molds, improper screwing, suckback, gases forming during casting. What if the alloy wasn't degassed correctly? So look at all these different variables that we had to put up with over the years. So you can see some pictures of the magnification of these alloys on the left-hand side. So, and a lot of contamination. And there was, especially with laboratories who really were trying to be frugal and using a lot of the old metal, mixing it with new metal, they get these detrimental effects with these alloys. So, thankfully at the NDX, we follow the rules, we do it the right way, so we got away from, a lot of these challenges over the years with alloys, especially when induction casting was introduced. And that's, induction casting's been around for a long time, but, it was more of a safe and, predictable way to cast your restorations. So, you can cast all dental alloys, precious and non-precious, and it has automatic frequency settings, and it's highly efficient technology with low energy consumption, and it's fast melting, and it's complete protection from any oxidation by using a vacuum and gas argon atmosphere, which we didn't have that previously with a torch. We didn't have that vacuum when we're using a torch, so we had that oxidation. So these features in these systems are amazing. So you have the coil rotation. You have programmable for titanium castings. You have programs that can store numerous different programs, and many user-defined parameters for each one. So you can store about 20 to 30 different programs in these induction casting systems now digitally. So you can put whatever kind of metal you're used to using, or a number of others, and it's this way when you cast, that's going to be cast correctly at the right temperature. So the new reality. So noble alloy is becoming at times more expensive than high noble alloy, and this is due to the rising cost of palladium. And a lot of this had to do with the auto business, with catalytic converters and things like that. And, palladium alloys are no longer the economical choice. So, you've seen how expensive palladium is now. So some of the newer alloys contain platinum now, and there are highly platinum, content in them, and chromium. So it complies with ADA noble classifications because of the combination of ruthenium and platinum, and it brings it to over 25% of noble alloy. So it's being used. The challenges that they're having sometimes with these types of metals is sometimes a CT between the porcelain and the alloy, but that's, from what I've heard lately, it's been adjusted, and it's much easier to utilize now. So, and the melting range for noble alloy is like 1250 to 1290. This is a little bit higher. So you have 1370 to 1420. So it's kind of technique sensitive, especially when you're screwing. You have to make sure the screws are away from the restoration, kind of an indirect type of screw. But it works out really well. A lot of good response in the industry now to this type of alloy. So I had to bring that up because it's something that's evolving in this type of restoration, PFM restoration. So I wanted to show the alloy market pricing as far as this morning goes. Gold was at $1,803. Palladium was at 1880s. This is per ounce, 1887 per ounce. Then you had platinum at 952, and silver was lowest at 2281. So the platinum is lowest. So it's more an economical restoration when you're using these platinum-based alloys for PFMs. So with that, I'm going to get into a little bit of zirconia options, and then we're going to have some questions after. I'm going to have a little polling questions for you. But zirconia options for full contour, that's an option as far as if you didn't want to do a PFM, ideal for patients with bruxism and parafunctional who have destroyed their other restorations. And it's an aesthetic alternative to PFMs. I don't have too much time to get into the zirconia aspect of it today because I wanted to get more into the traditional PFMs, but it has an improved gradation of color. It's available for single units and bridges with no span limitations. And that flexural strength is 1100 megapascals. It's a biocompatible medical grade for zirconia. And you can utilize and design CAD/CAM technology for precision fit and marginal accuracy. So that's mostly for full contour. Then we have our layered, and there's other types. There's about four other types of zirconia options that are out there. And I just wanted to mention some of the popular ones today. But when you're talking about the zirconia layered options, it's more for the anterior aesthetic region. And it uses layers of feldspathic porcelain over an anatomically supported framework. High flexural strength, reduction in seating time through the precise CAD/CAM internal fit and contact adaptation, high biocompatibility, improved tissue health, crowns and bridges with unlimited spans, and for restorations over implants. And And as far as, the prep design, I remember reading an article with Rella Christensen, Gordon Christensen's wife, and they said her ideal situation for making any crown was minimal reduction on a prep. So this is where zirconia comes in, and those positive aspects are there. And so just wanted to mention that. So cementation options, again, you can use resin reinforced glass items, cement. Some of the brands here, Reliax, Fuji Plus, resin cements, from 3M. And a lot of different companies have these cementation options for zirconia. So with that, this is the end of part 1 here. So I want to hopefully get through all these different modules here. And so we're going to talk about successful impression techniques. And now this presentation is usually a lot longer, but I took the removable aspect out of it and just stuck to more of the crown and bridge. But before we get started on traditional methods and materials on successful impression techniques, I'm going to go through a history, and I find this real interesting, the history of impression materials. So we're going to talk about the history of dental impressions, predictability with impression techniques, avoiding air entrapment, avoiding tearing and distortion, adequate inspection of the impression at the removal, moisture control, cleanliness of the tooth preparation, tissue retraction. We'll talk about the corded and double corded, and a lot of different techniques for that. Single unit crown impressions and multiple unit crown and bridge impressions. So we have a lot to cover. And as you can see, I speak fast. So we're going to go through this, and I'll try to keep it at a good pace here. So I usually load a lot of content into my presentations here. So we'll also, I'm going to get away from what we originally had, preliminary impressions, custom frame impressions, and stick to the crown and bridge side. But this was a survey I got. This is from 2019, right? And look at the digital impression that are being taken across the country. It's about 33%, and it was about traditional impressions were about 78%. And this is the latest survey that I received today. And this is annual impressions, digital and traditional. So traditional is across the country, and this is all information from the dental laboratories who receive work from you, the dentists. Still about 77% of traditional impressions are being taken, and number of clients who've had intraoral impression systems change in the last 12 months, it's gone up, so it's gone up. So it's went to 47 to 49%. So it's increasing little by little. And it's been successful, and you have to do it the correct way. I wish I had more time, to talk about digital technology today, but we're going to talk a little bit about, the traditional way of taking impressions. So with that, we're going to talk about the history of impressions. I love this slide presentation that I put together here because, I every time I present it, I'm amazed at how far we've come with impression material. So from the 18th century to the 21st century. So let's start with right in the beginning here. And in 1787, John Greenwood, he was utilizing beeswax for impressions, so, and not for anything, I still see some beeswax today as far as by registrations and border molding, and it just doesn't work that great at all. I even had a full impression once taken with a denture impression with beeswax. And it just didn't hold up, especially, if it's a little warmer out, the lab is warm, it didn't hold up really well. So we went from beeswax over to the first metal impression tray in 1820 with C.F. Del Bar. And that's when the first impression tray was made, metal tray. And then we had Greenwood's grandson. He decided to start using plaster of Paris for impressions. That was 1844. And when I started out in the dental laboratory industry in 1975, and I'm old, but 1975, we were still getting impressions, plaster impressions. Some of you might know these plaster impressions. They were quadrant impressions with plaster in a quadrant metal tray. And they had the metal tray would come apart from the plaster, and the plaster would have to be broken apart in the mouth to get it out because you had undercuts, on teeth. So we had to piece this back together in the laboratory. When we got it in the laboratory, we had to put separator on the plaster and then pour our model. And when the model was poured, we'd have to break apart those plaster away from the model and from the prep. And that's how we got, at that time, we had a lot of plaster impressions and even copper bands. I still see some copper bands today. So that was 1844. In 1848, Montgomery had a gutta percha, so he was using a gutta percha that was used in root canal for impression taking. So then 1862, it was wax with a plaster wash. So, and I don't know how well that worked out. That was from a gentleman named Franklin. And so that was, from 1787 to 1862, with how far they came with impressioning and impression materials. So now in 1874, SS White decided to start using modeling plastics, and these were the moldable, meltable type of plastics. And I still see these today, and they're utilized sometimes for making custom trays. And then in 1900, the Green brothers introduced modeling plastic, the method of utilizing the modeling plastics for impression taking, and utilizing modeling plastics to create a post dam in fully edentulous patients. And that's where they first, realized that post dams were an addition and to a good positive aspect of retention for dentures. And then we had Rupert Hall had the first custom tray, and he used a black modeling plastic for that, for a first custom tray. So I'm sure the other plastics could have been used for that also. But started utilizing the custom tray in 1815, and in 1925, polymer agar was used, which is a hydrocolloid material, but it wasn't for fully edentulous patients. So we came from 1874 to 1925 here. And now we're getting into more of the advanced stages here. I laugh because it's amazing. So impression waxes were developed. Aside from the beeswax, impression waxes were developed in 1920. And then we had Ward and Kelly, the first time of zinc oxide eugenol for impressions. And when I first started out in the laboratory in 1975, we were still getting a tremendous amount of ZOE impressions in the laboratory for full cases and for relines. And the only thing with ZOE impressions, would happen is some of the chemicals in those impression materials would get into the dental stone or plaster. And we went to process dentures. A lot of times we get a blanched or bleached look on the tissue side of the denture. But the accuracy of the ZOE impression material was fantastic. We always had some great results from it. So that was still being used, when I started out in the 70s, in the laboratory business. And then in 1940, right then, they had the first alginate impression materials, and it was used for corrective wash procedures. So moving on, we had in 1955, elastomeric impressions was introduced. That was your polysulfide and silicone base. So that's, again, polysulfide impressions or rubber-based impressions. They were beautiful impressions. We had some great accuracy, mostly on the denture side for the edentulous patients. And to me, the ZOE and the polysulfide impressions, we had some of the greatest accuracy for full denture patients. And then in 1973, the first moldable acrylic material was introduced for tissue conditioning and functional impressions, especially for patients who were having immediate cases at the time, or immediate dentures. This was utilized quite a bit. And finally, in 1982, 3M SP came out with their VPS material, vinyl polysiloxane, and that's what changed a lot of the the history of impression taking. Then different companies started to jump on board, coming out with different viscosities, different setting times, different quality levels of this impression material. So 1982 is when they first had that vinyl polysiloxane, and it's been used ever since. It's been improved over the years, and so then we're going to talk about all the different techniques and different solutions to different problems in the for taking impressions. So the essentials for a successful case, of course, we need the right materials. We're going to talk about shade in a little while. Bioregistration is important, but that impression is so important also. So we're going to talk about remake factors here. So the number one remake factor is still in the business, and it is inadequate impressions. Number two is inaccurate occlusion registrations, and we had poor shade communication and wrong choice of materials. And everybody hates remakes. We don't want remakes. We lose money. It's a lot of time. It's an inconvenience for you and the patient. So that's why we want to try to do quality control and get everything right from the onset of the case. So VPS, what are VPS impressions? It's made with a vinyl polysiloxane material, and it's widely used by dental professionals throughout the industry. It's still the number one impression material, and we'll talk about polyether in a second. That's also widely used. And it's intrinsically hydrophobic, increased hydrophilicity. and they have surfactants in the material. So VPS material is also sometimes called PVS. So I hear people say VPS or PVS, whatever you say is correct. But it's been around a long time, and they're available in multiple viscosities, precision impressions, and it can get confusing. I work for an impression material company for years, and I do a lot of lunch and learns at different dental offices on impression materials and what to utilize, and for crown and bridge and for removals. So it can get confusing. A lot of choices out there. Then we have polyether. So this enables excellent dental reproduction in a wet environment. It displaces moisture right from the start, and for void-free impressions. So and the polyether has been around a long time also, and it offers high rigidity after setting to keep everything in place. It's copings, and even with implant impressions, with open tray and closed tray impressions. And it stays flowable and throughout its working time, capturing the finer details of fewer voids. So we still get a lot of polyether impressions in the laboratory. So let's talk about some of the problems with impressions here, and how we can be more predictable with impression material techniques and materials. So when you're exceeding your working time, flowability is already impaired. So you want to select a material with sufficient working time, something like regular set instead of fast set. Don't exceed the working times given in the in the instructions used. So the instructions are there for a reason. So pay attention also to your storage temperature. Working times are reduced to higher temperatures of the product. And we see this with the acrylic side also. The warmer the room, the warmer the temperature, the faster things set up. Even with plaster and stone, the same thing. So then we have delamination of the impression material in a tray. So it's important to use a tray adhesive for all types of impression trays, and apply the adhesive on the bottom and inner sides of the tray. Also use that tray adhesive on the gauze side of the dual arch trays also, if you're using those dual arch trays. And certain trays on the market have a self-retentive fleece strip, which eliminates that and the need for a tray adhesive. But I still like that. I like the predictability of that tray adhesive. And then you have the lack of support or insufficient stabilization of the tray during the polymerization or setting time of the material. So you support that tray until the impression material is sufficiently set. Now, I've been in dental offices where the assistant is taking the impression, or the dentist is taking the impression, and they ask the patient just to hold the tray in place while then they left the room, and the patient is opening and closing their mouth and moving around the tray. It's not going to be an accurate impression. So we're going to stabilize that tray and avoid any movements during the impression taking. And when taking an impression of the upper jaw, you can easily find support on the chin or cheekbone of the patient. And with impressions on a lower jaw, patients should try to close their mouth as much as possible without biting down on the tray. This will give you more room to move around that tray, get that impression tray in the mouth. And try to avoid correcting that position of the tray after insertion. And distortions during impression removal. Just ensure that the impression tray is the proper size prior to taking the impression. The materials has that excellent elastomeric property. And remove the impression along the axis of the prepared tooth. And also make sure that the impression material is completely set before removal. I see a lot of times in the laboratory, we get these in, I'm looking under the microscope, and we see these impressions, and we know either the expiration date was expired or is removed before the material is completely set. And sometimes the impression trays are too flexible. You want to use rigid trays. Especially when using dual arch trays, impression materials with low flexibility and high shore hardness are beneficial to stabilize this impression. So I'm going to utilize materials that offer heavy body options that are suitable to use with dual arch trays. So, all these ones you see, Impergum, Polyether, these are utilized with those types of trays. And the combination, sometimes the combination of the tray and the impression material is not appropriate. So you don't want to use a highly viscous putty material with a flexible plastic tray. You're going to have to get distortion. And dual arch trays can be formed during impression tray taking, especially the flimsy, inexpensive ones. So you want to make sure that you want something that's going to be a little stable and durable when you're taking these impressions. So this is a major concern. What causes those unclear margins in dental impressions? So sometimes we have that thick blood saliva pooled around a preparation. It's not cleaned well. You want to rinse and dry the prepped area and stop any bleeding by using the appropriate retraction technique and a hemostatic agent. The liquids or paste based on aluminum chlorhydrate, aluminum sulfate, or iron sulfate are suitable for those hemostatic agents. And the same goes with, even with when he's taking a digital impression also, it's really important to do these same techniques. So use of an astringent retraction paste, you want to utilize the retraction paste. Sometimes I'm seeing combination of the cord and the astringent retraction paste. So the retraction paste is easy access to tight interproximal areas. It's long lasting. Hemostasis is achieved. Most of the time it's 15% aluminum chloride paste. It's gentle on the tissue with less risk of trauma and hemorrhaging, better for patient comfort and effective retraction. But I see doctors using both the astringent and the corded technique, and sometimes a double corded technique. This type of this. So the retraction cord must be cut to size for each procedure. Sometimes it's difficult to accurately place. So hemostasis is approved by pressure and usually requires the cord soaked in that hemostatic agent, like I mentioned earlier. So, and that risk of genital inflammation and trauma is higher than what we had earlier with that hemostatic agent. Sometimes it's painful for patients, but it does have excellent retraction. That's the positive side of it. So then we have some distortion through the inhibition of setting through the acid retraction materials. Aluminum or ferric salts. We want to thoroughly rinse those preparations with water and dry before taking the impression. So just make sure that's nice and clean before the impression is taken, and this way you don't have to worry about any contamination. And the inhibition of setting time with due to latex gloves. We learned this over the years the hard way. So use gloves which don't contain traces of sulfur, and that's nitrile. Most of the dental offices using nitrile gloves now. And then the impression material is stored at too low of a temperature. Temperature, like I mentioned earlier, influences the viscosity. So store the impression materials at room temperature. Lower temperatures might lead to higher viscosities also, which can lead to distortion. And storage conditions after disinfection of the we're going to rinse those impressions with water and dry before sending it to the lab, and store those impressions in room temperature and away from direct sunlight. And disinfection. So this is important. You want to utilize the right disinfecting solution for the appropriate impression material. And we've seen this over the years that the wrong type of disinfecting, the wrong type of glutaraldehyde with different type of impression materials, and we get some distortion. So, and just don't exceed the immersion time. This is where the problem comes in. When you exceed the immersion time, a lot of these disinfecting materials are the solutions. So what causes dental impressions to tear at the margin? We see a lot of tears on our impressions too, which is going to create a case that's not going to fit correctly. We're going to have to, we call the doctor and ask it to retake that impression. That has an effect on it too. So, and then you have smear layers from the custom temporaries, provisional cements, or core buildup materials. So you want to be sure to remove the smear layer completely prior to impression taking with alcohol or by polishing. So fabricate that provisional after taking the final impression. And remove the air inhibitor layer or the light cure material. It also has an air inhibitor layer. Remove that layer because it's going to cause a problem. With the setting time, especially around the margins. Okay, and then premature removal of the impression. We talked about that earlier. If it's not completely set, you're gonna have problems with that. So, and some of the impression materials have low tear resistance. Let me tell you, there's different levels of quality of impression materials on the market. That's why there's so many different impression material companies out there. So many different impressions to choose from. It can get confusing. So let the material completely set before removing the impression material, and then you have less tear resistance. So there's so many different choices of impression materials on the market, and so many different techniques. So it's no wonder that inaccurate impressions, are still the #1 reason for remakes. So this is what we have to look out for, and do your own quality control check before you send it to the laboratory. And what causes the voids in the margins for dental impressions? Well, we have a number of different things: blood and saliva contamination around the prep. Rinse and dry the prep area properly. That's really important. So, an improper syringing technique. I'm going to keep that mix permanently immersed in the paste to avoid the formation of bubbles. And I'll show you, hopefully show a short video on this in a second. But I'll apply liberal amounts of wash material into the sulcus, like you see here. Start from the bottom up and cover the whole abutment tooth with that syringing material. And always keep the tip in close proximity to the surface. And bleed the cartridge prior to loading. the syringe, because sometimes you get air coming out first, and you don't have an even flow of the base and catalyst coming out of the cartridge. We see this a lot, and that's what's going to happen. You're not going to have a correct setting time for this impression material. One part's going to set before the other. Some parts might not even set at all. So if you just keep an eye on that also. So this is just showing just in the impression tray, just to keep that tip in there and not pull it away. Otherwise, that's where you're going to have your voids. So it's just a short video here on this. So I hope you can see this okay. And then when you're doing, two different viscosities of the impression material, you have to do the same thing. Keep that tip inside, inside the tray. So stock tray versus a custom tray. Using custom trays for final impression represents a dentist's best effort to obtain exact duplication of the pair of teeth and the adjacent tissues. So literature demonstrates that the optimum accuracy is obtained with custom trays. But there's a lot of quadrant trays and trays out there that are on the market today where you can actually you can adapt them, heat them, and make it almost like a custom tray. So a majority of dentists use stock trays for final impressions. We have to remember when pouring a putty wash technique, a rigid tray and well-fitting stock tray is acceptable. So a putty wash two-step technique with controlled bulk and the stock tray can be used as an alternative to custom trays and provides accurate impressions. So it's going to be more of a rigid type of impression. So this is just showing it, just a different viscosity technique on here. You have more of a heavy body monophase material on the inside and using a light body material to get a better impression and get better detail around. Even with opposing arch, or the opposing arch that you're going to be utilizing for these types of cases. So dual arch trays are often used to generate impressions with prep teeth of the opposing arch simultaneously. So there is a concern that the accuracy of these casts generated with this technique can be affected by the type of tray, viscosity, and impression material, and sequencing of pouring the cast. So let's talk a little bit about crown and bridge impressions here. So we did the looking at the different possibilities of errors that can happen with the different materials. But when you're taking a crown and bridge impression, I'm sure you all know this, light body impression materials applied to the prep teeth, capture the detail, and this material is less viscous and wets the surface, perhaps better. So you have a fast setting material, you have medium setting, you have slow setting material. So just make sure you get the right material for what you're used to. And then heavy body material or monophase material is placed in the tray and then placed over the light body material to form that impression. And you'll still get a lot of, many types of these triple tray impressions or dual arch impressions. But that heavy material provides stability to the impression for better accuracy. And then we take the opposing, where the opposing patient bites into the impression material until it's set. So then we have a bite registration and the impression of the prep at the same time. And what I also like to ask for the doctor just to send possibly an additional bite registration. Maybe take a polyvinyl bite with a bite registration material in addition to what you just sent with the triple tray. This is going to ensure us and give us the possibility to check if the bite is correct. I see a lot of times that the bite is distorted. The patient might be sliding a little bit when you're taking the bite registration. So that extra bite registration, you can use a polyvinyl material, really helps us in the laboratory. So let's move on to implant impressions. Let me check my time here. 9:13, good, okay. Implant impressions, implant level or abutment level impressions with open tray or closed tray techniques. So the open tray technique, you can utilize a stock tray to make openings. That's great. Now we have CAD/CAM produced trays with exact openings, which is great, or we have the custom tray options. There's a little video here. Doctor's using the open tray technique here, trying to get that screw loosened here. So he created holes in the stock tray. And he's going to take this impression out of the mouth here. And I'd like to show this just to show that sometimes it's just not enough material in the tray. It's hard to see that time, but we want to make sure we have enough material in that tray and get a good impression. So something like this, I think we're okay. But I think we would have gotten a little more compression if we had a little bit more material in there. So it's coated with adhesive and a heavy body impression material. So light body impression material is expressed around the copings to capture the morphology of the soft tissue. And it's important that we get that soft tissue impression also, because we have to pour a soft tissue model. So that's one of the reasons why we want that good detail, even when we're scanning it. Even when we have an in-lab scanner with scanning these, we want to make sure the detail is there. So monophase impression material can be used as a convenient and practical alternative to the combination material, but just make sure you use a Q-tip to wipe across the occlusal openings of the coating so the screws can be located before it's polymerized. All right, so it's easy access for loosening. So, and just a little some pictures of the open tray technique here. This is again with a stock tray in the heavy body material. And closed tray versus an open tray technique. Well, the open tray technique is specifically indicated when the implants are not sufficiently parallel to allow an impression to be withdrawn from multiple impression copings. So, the closed tray impression technique is utilized when the implants are sufficiently parallel to each other. But try to keep that in mind, when we're worried about what should I do, open tray or closed tray. So, the closed tray technique, stock or custom tray can be utilized. Closed tray impression copings are placed on the implants or multi-unit abutments, and the impression is made. And once the impression material polymerizes, the impression is dislodged, and then the closed tray technique copings are then removed, and implant abutment analogs are attached to the copings. Then we have our model analogs that we put into the impression at the laboratory, and we pour our soft tissue model. So things to consider though: implant impressions, you want to choose a custom tray, full arch, or quadrant impression, and take a separate by registration for best results. And when using that dual arch impression tray, make sure that patient does not bite into the tray to support it. Use a heavy body material in the impression tray and a lighted bottom body material around the impression coping to eliminate any boards. And just keep in mind, the open tray technique is required when implants are not parallel and the path of insertion is divergent. All right, real quick on pickup impressions too. When you're doing a pickup impression, whether it be on a denture or an existing partial that we have to make a crown on the partial, just be careful that impression material is not too rigid, because sometimes it's hard to get that framework out of the impression, and sometimes it bends. So it's difficult. We have to cut it out sometimes, but especially when we're making a crown under a partial. Just keep that in mind. Okay, then digital technology. I'm just going to touch on real quickly here because I think I'm not too sure we're going to have enough time to get into the full presentation with the with shade taking here. But digital technology, again, utilize the same methods as I talked about earlier. With isolation, lift cheek retraction also. Just make sure you utilize the right tools for coordinate techniques, just to have confirm you have adequate preparation reduction for occlusal clearance prior to scanning, because that's really important. And you can use a BiTab, perio probe, or something called prep check. That's great also to make sure we have occlusal clearance before scanning. And then we could see on a large screen here, even if you scan, you can actually see if there's an opportunity for improvement and inadequate tissue retraction and data capture. Let's look at the picture on the left. There's really not, it's not a great impression. So we're going to have to do some more tissue retraction for adequate data capture here. So look at this. This is textbook gingival tissue retraction. A supragingival Frigish line is preferred. However, if subgingival, achieving apical and lateral gingival tissue retraction is required for the optical device to obtain the data, then this can be accomplished with a retraction cord or retraction place. And in some cases, you have to use a laser. All right, so just make sure get good accuracy. Look at the top. This has without proper isolation of the gingival tissue, and on the bottom it shows us the retraction paste utilized in a dry field. And look how nice and accurate that is on that lower photo here. And again, retraction cord. You have all these different tools at your fingertips here to help you take good impression. So great impression ensure well-fitting restorations, and the dentist must evaluate what type of impression is being taken, and then to choose the correct impression tray, method of tissue retraction, and the appropriate impression material. When it comes to evaluating impression material, a number of factors need to be looked at, including setting time, detailed reproduction, quality of the material, and dimensional stability. So the ultimate goal here is patient satisfaction. So again, the reason why I brought this up tonight is the number one cause of remakes is impressions. So with that, this is the end of part 2. Let's get into that. And shade science and communication. I can get through a number of slides here. I just want to mention a couple of things with shade science and communication. So, just understanding of science and theory and shade taking techniques. So we're probably not going to get into the manual and electronic shade taking, but I'm going to skip through here. But again, primary cause of remakes, 30% of remakes are because of poor color match. So that's something to look at. Number 2 is open margins when it comes to shade taking. When it comes to remakes, open contacts, defective material, and most common causes for color mismatches: too bright, wrong hue; too dark, too opaque. So between the impressions and shade taking, so they really add to the if it's not done correctly, they add to the remake factor. But we look at these different shades on the different lights. We want to make sure, look at the different shades. This is under different lighting conditions. So it can really throw you off when you're taking a shade. So what's one of the best tools of color is your eye. And you have to utilize illumination and a sample or object to interact with light energy and a receiver and processor, which is, we have the shade guide, the light in your eye. So it's important, And the perception, a lot of things happen in the operatory when you're taking a shade. A lot of times we're taking shades in the laboratory. So, when we have no light, no color, light that reaches our eye when we view an object, that's perception. This light has been changed by the object, and interaction with the light and the object allows the perception of color. No light, no color. So if you look at this on the screen here, it's actually plays tricks with your eyes. And the same thing happens when you're taking a shade. Are the horizontal lines parallel, or do they slope? I like this one here. Is this a column in the middle, or is this the back wall? And then we have the nuns walking here. Are they all the same size? Well, the ones up front larger. They're all the same size. Our eyes play tricks with this in the operatory also. So these are just some of the terms and properties of light that we have to look at. I'm not going to go through all these today, but all these play a part in what we do when we're creating a crown, especially a porcelain fused to metal crown or a layered zirconia crown. All these have an effect. So I'm going to skip from here, and I'm going to go, if you see this on the screen, I'm going to go down to the actual shade taking here. So this is the a three-dimensional model. Let's see if I can get this over here. This is a three-dimensional model of the color module here. Let me just hide my controls here. Yeah, so the color sphere, this is a color sphere, and represents the entire universe of color, and scientifically known as CIE sphere. And it was created as an international standard for color representation. So, and it expresses it's expressed in nearly every industry today that has to do with the color. It contains over 10 million color variables within that sphere. And the lightest of our value of colors is the highest at the top, and the chroma is the richest in saturation, originates from the core outward. And the reason why I'm going to show you this is because I want to show you what our shade taking system covers in the sphere. Oops, there we go. Good. So I'm going to pass through here. I'm going to just show you here. Sorry, I'm rushing here. I know we don't have much time here. So this is one of the original shade guides here. And this is what we have to choose from in the marketplace. And the most accurate ones I see on the market now is the Vita 3D Master Shade. So that covers all those intricacies that we need to take a shade, those half shades. The original shade guide, the current system, what we had for years was this Vita Fan Classical shade. And that was more of a value-based shade guide. And it wasn't really a scientific shade guide. And it was really meant, when it was made, it was meant for denture cases. And it meant to take shades for denture teeth. And it was acclimated over the years on a crown and bridge side. But it had limitations. It had color gaps that we have those color gaps fulfilled with the 3D Master Shade Guide. And it wasn't systematic. So this was the current shade system that we had. And you can see that's outside the color space of that sphere that we just showed. And So now with the this, as we see, this is a 3D from A1 to D4. You see those different classic shades. Some of them are going outside the color sphere here. So, and it's based on value of this whole shade guide. So now we went from an intuitive arrangement to a more scientific arrangement here with the 3D Master Shade Guide. And we go from lighter to darker across the board here, from 1 to the 5 range. We go to richer to paler, and we go to reddish, yellowish to reddish. And now look at that; they're orderly and equidistant with these shade guides. Now we got the 1M1, 2M1, 3M1. We have all these half shades that we can take now and be accurate with. So it differs from each shade being uniquely extending the range, yet doubling the perceived tooth shade space and in between shades that are possible. So which is great. So now we have these 26 shades, which I showed before with the sphere. They fit accurately within the tooth colors, and is systematically used and addresses the need for additional shades with high or low values, which is great. And 17% of the shades measured with conventional shade guides need a required correction. 99% of the shades measured with the 3D Master Shade Guides needed no further correction. So let's just talk about what influences us and what are the basics and what do we need when shade taking. So we have to consider hue, chroma, and value of contrast. This is the same restoration with different lights, different lighting. So look at the difference. So we can get confused when we're taking shades with the wrong type of lighting. So operator influence, sometimes we have color deficiency, troubleshooting red. It's more prevalent in males than females, and it's the absence of photosensitive pigments in the eye. So if you can see that number in the circle here, you're okay. But I just wanted to bring that up here because 1 in 300 females are color deficient, 1 in 13 males are color deficient. So that, with that, operator influence, it increases and starts after 30 and it's noticeable after 50. And that's when your cornea starts yellowing. So, and some of the operator influences are colors cannot be perceived accurately by tired eyes, and color may be faded or blurry, and it can create a mismatch. Motions have an effect on pupillary diameter, which can affect shade taking. And two identical objects placed side by side appear differently. So placing a shade tab above or below the tooth or on either side can have it as an influence. So you can see here, the shade appears very different when these two identical A1 shade tabs are side by side in different maxillary and mandibular positions. And, bleaching, people want white teeth. So, color saturation or chroma is greatly reduced with bleaching also. We also have there's also a bleaching shade guide on the market that you can measure this bleaching. So I'm going to jump here because of the time factor here. I'm going to jump to shade taking procedures here. So when we look at the shade taking procedures, patients should be in an upright position and position that tab in the same position as I just showed, maxillary or mandibular as a tooth being measured. Always view the shade guide for both direct and slight indirect viewpoints. And always take that shade before prepping the tooth. Verify that shade after prepping only if the adjacent teeth have been kept completely hydrated during prepping. Really important. My screen froze here. Here we go. So let's talk about the 3D Master Shade Guide, instructions for use. I remember when I used to work for Vita years ago, and when this 3D Master Shade Guide came out, everybody was buying them, but nobody knew how to use them. So a lot of times, in the beginning, we sell these shade guides and it wound up in the drawer in the operatory. Nobody really knew how to use them. But so what we're going to try to do with this 3D Master Shade Guide, the first thing we want to do is to determine the lightness of the value. We're going to hold that shade guide at the patient's mouth at arm's length and select one of the groups, 1, 2, 3, 4, or 5. Look across and start with the selection with the darkest group. Once you determine that lightness value or level of value, and then we have to select a chroma. That's usually up and down. So once we take that shade tab out of the slot there, on the basis of lightness level determined, take the middle group, like for instance M, and spread them out like a fan. And then you can select one of these and you can select the chroma. So that's the second thing you want to do. And now determining the hue, we check whether the natural tooth is more reddish or yellowish than the shape the shade sample selected from left to right. So this still sounds a little complicated, right? So then the newer method now of doing this is now with the linear shade guide. And a lot of the universities have this now. They're using this in the universities. So instead of doing a 3-step process, it's an improved 2-step process. It improves faster in shade selection process. As you can see here, everything's broken up into these 6 different sections here. So, so you have the 3D master shade guide, and you have your value, which is the darker one on top, that darker shade guide on top. And then you have your chroma, and then you have your U in one shade guide. So I'll show you what you do here. So this is the linear shade guide. First thing we're going to do is take that top, the darkest one out that you see here, darkest card. That's going to give you a value. You choose a value from 1 to 5. And all you do is, once you get that value, this is a 2 group here. You go right across and choose your chroma and U. So it's a 2-step process of taking the shade. It works out really well, and it's it's an accurate way to take a shade. Instead of going to 3-step, you have the 2-step there. So a lot easier to take the shade. Once your selection has been made, confirm it with another team member. Have the patient look through the hand mirror and accept the distance. And once everyone is in agreement with it, write the shade on the patient record. Because if the patient's not happy, nobody's happy. So, in conclusion, shade matching of dental restorative materials with natural teeth is vital, producing restorations that are natural looking. And patients expect a clinician to restore missing and broken down teeth to an acceptable aesthetic appearance. So, a better understanding of the physical and physiological processes involved in human color vision, color theory, and shade science should enhance the appreciation for the challenges associated with tooth selection. And shade selection. So, it's challenging. Impressions, shade selection, and the use of materials, really have to know all this, and everything comes into play for the patient satisfaction. So, oops, let me, sorry about that. So thank you everybody for joining us. And if there's any questions, you can email me at derp@dentalservices.net. Thank you for your time and for joining us, and it's been my pleasure.